Welcome. My name is Littlefield, and we'll be addressing depression. Clinical presentation, history of present illness. My case is about Janelle. She's a 35-year-old woman with chronic depression and presents to the office with concerns regarding her current medication, fluoxetine. Fluoxetine is an SSRI, and SSRIs tend to be first-line medications in the treatment of depression. And they tend to have less side effects and interactions in comparison to other medications and generally work well overall. History of present illness. She's a 35-year-old woman with chronic depression who has been on fluoxetine 40 milligrams daily for a year. She says she has been on this a year. This does tell us a few things. That when you're first started on a medication, you are reassessed a few weeks in, and then again, usually a few months after that. So, based on that alone, it does tell us that it must have been working for her, having been on it for a year. She has not been changed from a different medication. This is her first medication that she's been put on. And she scored initially an 11 on the PHQ-9 last year. And this is a tool that's used to help us evaluate the severity of depression. And it's not a diagnostic tool per se, but it does help us overall while we're looking at other signs and symptoms. We can also use this as a tool to kind of pinpoint where they might be at in that spectrum from mild to severe. She states she's feeling a little bit better, but she thinks that she's not as happy as she should be, having been on this medication for a year. She sees a counselor, which is great. We know that combining medication with therapy is better, and it provides way better outcomes than just medication alone. She reports sleeping all day before work and is somewhat irritable and fatigued. She has an abnormal work schedule. She's working long nights and getting home in the early morning, sleeping all day. This could contribute to her fatigue. It's kind of hard to differentiate between this and her depression, which one that might be part of. So that's why it's important that we also address lifestyle changes to help differentiate, hash those things out. She reports that she's stressed about money, and counseling notes that she's stable but exhibits some hopelessness surrounding her, current situation. She feels like she's not working towards any goals. She's kind of stuck in a job that she doesn't like, and that's also adding to her depression. Clinical presentation and past history. So her medical, she does have hypertension. This isn't a concern currently fluoxetine, but it can be a concern if we decide to switch her to a different medication in the future, such as an SNRI. Some of those medications can worsen hypertension. Anemia, we want to make sure that her anemia is not worsening. This can also be very similar to signs and symptoms of depression, so we can talk about that a little later, about labs that we might want to do. She was last seen a year ago, which is when her fluoxetine was started, and then since it's been going well, she's been managed via phone updates. She denies surgical history. She reports being hospitalized for SI a year and a half ago, which was before she was started on her fluoxetine. Family history is a good thing to keep in mind, especially since her mother has a history of depression and Hashimoto's. She might want to have some endocrine related testing done, which we'll talk about in a bit, just because, again, signs and symptoms of endocrine related issues such as hypothyroidism can be similar to depression signs and symptoms, so we might want to check on those things. It's also good to know, what her mother used for medication, knowing what worked for first degree relatives specifically is sometimes a good starting point when we're first starting someone on medications, especially if that person does know what did or did not work for them. And then social history. She was born and raised in Maine, received her GED after dropping out of high school at age 17, worked as a waitress. So it seems like there's a lot of ongoing stress for her. Reports working long nights at work and sleeping all day. That irregular schedule is also probably not helping with her sleep schedule and contribute to her fatigue. She has no children and has a pet cat. She has a long-term relationship going on, but she doesn't socialize outside of that. And then she also states that she doesn't have any hobbies and likes to keep to herself. So that isolation isn't a good thing. Getting out of the house and having something to look forward to is really important. She denies exercise because she has no time, and she says she eats a diet high in carbohydrates and sugar, and specifically overeats when she's stressed. So, if we can find a way to limit that stress, that would help with eliminating these bad habits. And then safety issues are also really important to ask. She does deny owning firearms and reports feeling safe in her current relationship, especially important for her where she does have a history of SI. And then she denies alcohol or drug use. And she has no known drug allergies, and her medications include lisinopril and iron, which both should be fine with fluoxetine. There shouldn't be any interactions. Clinical presentation continued. Review of systems. So for this, I focused more on areas that I thought would present with positive findings. Obviously, this might not always be the case, but for this scenario, I tried to pull out pieces that I thought were most pertinent for her. So general, she complains of, malaise and low mood, which we already talked about. GU, she denies a history of sexual or physical abuse, which is important to ask because this can be a trigger and should be addressed, especially in therapy sessions. Here, not much of an issue since she did deny it, but still always something we want to know. Endocrine is especially important for her. Her mom does have a history of Hashimoto's, so we'd want to dive a little bit deeper into this when we assess. We want to ask more questions. She did deny the cold and heat intolerance, but also asking if she's dealing with constipation, weight gain, brittle nails, and so on. She is having the fatigue, which can be part of the depression, but also be endocrine related. And I'll talk a little bit about this more in the next slide when we touch on labs. Neuro, she's sleeping 10 hours a day and night, and we talked about this, about trying to figure out a better schedule for her that would allow her more of a consistent sleep schedule and possibly looking for another job. She denies SI and HI, which is extremely important to ask. We want to make sure she's safe. And she's currently seeing her counselor. Again, want to address and make sure that this is still a therapeutic relationship for her and it's helping. And then feeling hopeless and stressed, we talked about already as well. Musculoskeletal, she reports myalgias, which are pretty common with depression, and she denies arthralgias, no history of fractures or sprains, and then no other positive findings upon exam. Clinical presentation objective findings. So vitals look good. Her lisinopril is doing its job with the BP. Physical exam. She's of average height and weight. So weight is a good thing to always look at. If she's over or underweight, those can be signs and symptoms of depression as well. She is a young single woman with flat effects, slumped posture, and slow movements. Right when she walks in the door and as she walks to the exam room, that's kind of a good thing to look at. Her gait will give us a good idea of how she's moving and also her posture. She presents with a calm but disheveled appearance, which could be attributed to her, lifestyle of having an erratic schedule, or also just not having the energy to get up and get herself together in the morning, which is part of depression as well. Other findings upon exam, general, flat effect, which we already mentioned, and then neuro, slow speech. Screening tests, again, we talked about the PHQ-9. This is a good test to use to kind of pinpoint the severity of depression and also gives us a way to compare where she was at previously. So she, I believe, was at an 11 we talked about earlier, and now she's at a 7. So a 7 is considered to be mild depression. And this isn't a definitive diagnostic tool, obviously, but it is, again, a good way to help us assess. And so if you look to the right, that just gives you examples of questions that are asked. The scoring goes like this: 0 to 4 is minimal or none, 5 to 9 is mild depression, 10 to 14 moderate, 15 to 19 moderately severe, 20 to 27 severe. Labs, we'd want to look at probably a TSH due to her family history of her mom having Hashimoto's, and because she has, fatigue and things like that that kind of mimic endocrine related issues. We'd also want to ask other questions such as, weight gain, which we already addressed up top. Does she have brittle nails? Is she dealing with constipation? Things along those lines, so that we can sort of differentiate what's going on. And her lab results here were normal. CBC, we'd want to check maybe a hemoglobin hematocrit due to her anemia, just because those signs and symptoms as well can be similar to depression signs and symptoms. And we want to make sure that her anemia is fine and it's not worsened. So those are normal results as well. LFTs we want to look at because this is metabolized by the liver. It's a cytochrome P450 drug. We want to make sure her liver is functioning appropriately. And CMP just to look at some kidney function because it is secreted by her kidneys and about 15% by feces. So we want to make sure both those areas are okay. And then no needed imaging at this time. Treatment plans next up. So we want to continue to stress lifestyle changes. Continuing therapy will also be very important. As we know, combining therapy with the medication will provide better outcomes for her in the long term. Stress reduction techniques, which may mean yoga or meditation, whatever she finds helps her reduce stress in her daily life, will be very beneficial. And then sleep hygiene, she has a very erratic schedule. Coming up with a sleep schedule, going to bed at the same time and waking up at the same time will be helpful. Taking the TV out of her room, limiting caffeine before bed, making sure it's dark in her room and there's no distractions will help her get good sleep. Healthy eating habits. She is eating a lot of carbohydrates and sugar, she says, when she's stressed. So if we can reduce that stress level, hopefully we can eliminate that sort of binge eating habit she has. And then just talking about a balanced diet and how important it is. And it also will make her feel better as well, physically and even mentally. And then she also isn't socializing and she has no hobbies, which isn't good. That leads to her being more isolated. So if we can get her out of the house and also have something to look forward to, that would be beneficial. And she's also not exercising. So even if she gets out of the house every other day and meets a friend for a walk, this kind of hits on both of those points. She's getting out of the house, she's moving, she's releasing endorphins, which elevate our mood, and she's also socializing with a friend outside of her, cat and her boyfriend. And then from there, we would, consider, again, increasing that fluoxetine dose, which would probably be the next step in the process for her. E-medicine does state to increase by 20 milligrams. And that's, because of side effects. We just want to make sure that we're going slowly and then reassessing. And hopefully she does not have an increase in side effects. And also, hopefully the dose does provide positive effects. And then just to keep in mind that, again, the max dose is 80 milligrams a day. So from there, hopefully we won't have to wean her off of this medication, and it does work. We would reassess in 6 to 8 weeks. In general, the ACP guidelines state 6 to 8 weeks is about the time that it takes to see any sort of change. So we would talk to her, see how she's feeling. The American College of Physicians, ACP, guidelines really stress the importance of, listening to the patient and hearing what they say surrounding how they're doing and what they have tried in the past, what has and hasn't worked, and not just going the route that we think we should be going, especially with this type of situation and mental health in general, we have to rely on what the patient says that they're feeling. So from there, if she, isn't really feeling much improvement, we can consider other medications such as SNRIs and Wellbutrin. Wellbutrin addresses dopamine and norepinephrine as well. So we're going above and beyond that serotonin that we're getting with SSRI. These also can be a little bit more activating, so that might help her in this particular case as well. We just need to keep in mind that these medications can also worsen hypertension in some cases, and she does have hypertension, so that's just something that we want to be aware of. Rationale and goals of treatment. So again, the first step would be to increase the dose of fluoxetine, because she had seen that, somewhat positive outcome in that year, not to full effect, but some. So we will go from there and increase from 40 to 60 milligrams a day, keeping in the back of our minds that max is 80 a day. Fluoxetine is also used for OCD, which would require generally a higher dose. But in this case, depression, you kind of just titrate up. Additionally, SSRIs are first line for treatment of depression. The APA states that they are first line for especially late onset depression and in adolescence. Fluoxetine is actually the only one approved to be used in adolescents, and UpToDate also recommends SSRIs as first line for moderate to mild depression. So they do have generally overall less side effects and interactions with foods and drugs, and lower toxicity risks. Unlike MAOIs, they had, more side effects, and they also interacted with foods with tyramine. Tricyclic antidepressants were a lot easier to overdose on, where these just are, it's really hard. You'd have to get your hands on a ton of these. So it's very unlikely. So specifically for this situation, where she does have a history of SI, that's good to know. Also, it doesn't affect her blood pressure. Fluoxetine doesn't, whereas some of the other medications such as SNRIs can worsen hypertension. And fluoxetine has a long half-life, which is good to know with her erratic schedule. If she does miss a dose, she won't go into withdrawal symptoms. The half-life is about 4 to 6 days, which is pretty long. And they also tend to be reasonably priced. We want to check, GoodRx, and at that specific time, it can change. But generally they are covered and reasonably priced. Typically, probably $20 for a refill of this prescription, but again, that can vary. Other goals include, continuing therapy and lifestyle changes. Depression isn't always solely related to neurotransmitters. It can be related to, intrapsychic depression, which is much harder to treat with medications and really just requires intense therapy. So as we continue to hash this out, those are important factors to keep in mind. And then overall, the end goal is to obviously increase the dose to increase the effects of the medication and decrease signs and symptoms of depression without increasing the side effects of the medication. So to, reassess and see where she's at, especially regarding, side effects and effectiveness of the medication. And then we'd also hopefully want to avoid tapering if possible. Obviously, that's a process, and it does entail withdrawal symptoms, and it can just put her at higher risk for, relapsing for more severe periods of depression. And it's frustrating. Patients want this to work, and, the more we have to try, the longer it takes, and the worse they feel. So, if we don't have to go through all of that, that would be great. adverse reactions and interactions of fluoxetine. So common adverse side effects are definitely those anticholinergic side effects. We also see nausea, which usually will eventually not persist throughout the treatment. If someone can withstand the nausea in the beginning, it eventually will subside. Sexual dysfunction, delayed ejaculation and orgasm, restlessness, and then serotonin syndrome, something we also want to keep in mind because it can occur, especially with interactions with other drugs. And a lot of times people think it is an anxiety attack, a panic attack because of the symptoms. So people tend to be anxious and shaky, warm, sweaty, tachycardic with serotonin syndrome. And you can see why they think that this was a panic attack. So we want to keep that in our minds and, let patients be aware of that. Also, dry mouth, and we sometimes see QT prolongation in people that have a history of this. We want to be more cautious. Hippocrates states if we can avoid prescribing this in those people, that's best. But if we can't, then we want to do an ECG at baseline and then also throughout treatment monitor. Black box warning of SI is still there. This is approved in adolescents, but it's not approved in patients less than 7 years of age. The SI black box warning for fluoxetine is more so in patients that are younger than 24 years of age. So kind of in between that, older than 7, but younger than 24, there tends to be an increased risk. So we want to make sure to monitor that. In this scenario, it's not a problem because she's older than 24. But, still monitor, of course. Drug interactions, amiodarone and azithromycin do increase the QT, so those should be avoided with this medication due to the QT issues to begin with. We don't want to make that worse. Other medications that can cause serotonin syndrome include things like Dayquil, Robitussin, St. John's wort. Those things are really important to let them know about because they can just get those on their own. They don't need a prescription, and it would cause, those side effects and possible interactions of the serotonin syndrome. And then also tramadol and the triptans, Imitrex, those also cause serotonin syndrome. So another thing to be aware of because those are commonly used. So when we're looking up our drug interactions, we just want to pay close attention to those things that can increase the serotonin levels. And then clopidogrel is known to increase the risk of bleeding as well. And there's a few others that were listed to do that too. So just another notation to have in your brain. Next up is pharmacodynamics and pharmacokinetics of fluoxetine. So pharmacodynamics, fluoxetine is a selective serotonin reuptake inhibitor. Essentially, this just means that it blocks the reabsorption of serotonin, which increases the levels of the neurotransmitter in the brain, hopefully aiding in stabilizing their mood and decreasing depression. It might not work perfectly for everyone, but it is a good starting point for sure. Pharmacokinetics, it's converted by the liver to norfloxetine by the CYP2D6 enzyme. This is a cytochrome P450 drug. According to the U.S. National Library of Medicine, norfloxetine is the active metabolite of fluoxetine. So some individuals may have a genetic alteration in the enzyme, making them unable to metabolize as well, which causes an increase in fluoxetine, resulting in an increase in adverse effects. So it might not work as well for them, and then they also get those increased adverse effects. So it's important that we, follow and reassess how they're doing and, make sure that it is impacting and providing a positive change for them and not causing an increase in those adverse side effects. It's also excreted by the kidneys. So as we mentioned earlier, it's important to touch on those labs, make sure those are working appropriately. And then at the bottom here, I did put a nice little video that goes over this in about a couple minutes about how this all works, the pharmacokinetics. So you can take a look at that. Fluoxetine patient teaching points. So just reminding her not to suddenly stop this medication without informing us. Yes, it has a long half-life, but eventually she will have those withdrawal symptoms, and it's always safer for her to inform us of what's going on. Just reminding her that it does take a few weeks to take effect and to hang in there. Lifestyle changes, again, are important, and to continue therapy. And then serotonin syndrome, just to advise her of, signs and symptoms and over-the-counter medications that can have those interactions. So she is aware and hopefully can avoid those medications. And then we'll just remind her again that we'll reassess in 6 to 8 weeks and see her in the office, but to always call with concerns, just so she has something to look forward to, that she knows that this is going to be readdressed. And then when we're going over all of this, I like to use something called the teach back method, just where they, kind of repeat back to us what the plan is, and it ensures that we're all on the same page and that the patient understands what's going on and how the medication works and all of that. And then also ensuring that she asks any questions that she has, so she doesn't feel like she's leaving the office and not having been able to put her 2 cents in. And my last page is just about references. So I hope you enjoyed this presentation and that you learned at least a little something. Thank you for listening.